Hello, everyone, and thank you for joining us today. I'm Jen French. I'm the ABC or American Brain Coalition Board Chair. We're thrilled that you are joining us today for this very special series that we are hosting here. This important topic as our educational series on mild cognitive impairment, or MCI, which you'll hear us saying that quite frequently
Hmm.
during this series. This is actually a three-part series, generously sponsored by ABC corporate partners Eli Lilly and ISI. We appreciate their support in making this available. We also want to give some special thanks to our steering committee for helping us organize this, the ABC member organizations, which includes the Alzheimer's Association, the Cure Alzheimer's Fund, the Dementia Society of America, the LEAD Coalition, the Lewy Body Dementia Association, the Association of Frontal Temporal Lobe Degeneration, and Us
Mm.
Against Alzheimer's. So, really want to give a wonderful, um, thankful welcome to Ian Kremer. Ian is the executive director of the LEAD Coalition, which is leaders and engaged on Alzheimer's disease. He has been extremely helpful in formulating this whole programming and working with our steering committee and is
Mm.
moderating all three of our sessions. So again, want to thank the for you for attending, for yeah, Ian for being here and our panelists for being here. This is a webinar mode, so when you do have questions, please put those in and we'll open that up. But at this time, I'm going to hand it over to Ian. Ian, please take it away.
Great. Thank you, Jen. And thank you to ABC for the opportunity to lead this series of conversations. Good morning, everybody. And to reiterate Jen's welcome, thank you for joining us for this important
Mm.
series of webinars on mild cognitive impairment. And Jen is right. We're going to say MCI a whole lot over the course of these three sessions. So just a little bit about me and the LEAD Coalition, just to set some context. I've worked in Alzheimer's disease and related disorders from a public policy point of view, 15 plus years on state and local policy, and then the last 14 years working on federal policy through the LEAD Coalition. And the LEAD Coalition is what it sounds like. It's a coalition. We've got about 280 organizations that participate either as members or allies of the coalition, about 500 predominantly university-based researchers, and we're all working collaboratively to try to advance
Mm.
risk reduction for Alzheimer's disease and related disorders, improve detection and diagnosis, strengthen both clinical and non-clinical supports. The point of doing that, of course, being to enrich quality of life for
Mm.
people who are living with these conditions and all the people in their ecosystems, family and non-family supports, and ultimately to advance the science so that we can overcome all of these disorders, make sure fewer people have them, that the disorders occur later if they occur at all, and with lower intensity for the people that are facing these disorders. So with all that as background, I want to welcome you again and thank you for joining us for this first
Mm.
session in the webinar series on mild cognitive impairment. Today, we want to ground the conversation in a shared understanding of what MCI is, how it differs from normal aging and differs from dementia, and why it is so important to pair the clinical perspective with a lived experience perspective. So I am just thrilled to
Mm.
be joined by our esteemed panel. We've got Dr. Ali Atri, who's the Chief Medical Officer at Banner Health, Dr. Ron Peterson, who's a neurologist and professor at the Mayo Clinic, and Reverend Cynthia Hewling Hummel, who will share her lived experience perspective. And I'll just say on a personal note, Cynthia and I are buddies and have been for a long time. Very fond of Ron and Ollie as well, but Cynthia and I hang out at airports and talk about just the rigors of life and the joys of life. So a special shout out to my buddy Cynthia. With that, I'm going to ask each of our panelists to introduce themselves. And
Mm.
Ollie, if I could ask you to go first.
Sure. Thank you, Ian, and thank you, Jan, and really appreciate ABC providing this series and the sponsors to be able to talk about this. important topic. So I'm Ali Alireza Atri. I'm a cognitive neurologist. As you mentioned, I serve as Chief Medical Officer for Banner Research. It's a healthcare system in Arizona and several states. And I also direct the Banner Sun Health Research Institute here in Sun City, Arizona. And I still have an academic appointment in Boston at Mass General Brigham, Harvard Medical School, going back and forth, doing a lot of teaching and some research, collaborative research. But ultimately, I take care of patients and families, for the last 25 years or so, I've been a one-trick pony. That's what I do, and I take care of patients and families that oftentimes have probably a little bit like Ron also had a bit of a rocky road to get to us. They've seen multiple neurologists, psychiatrists, and in my case, I specialize a little bit in early onset, so people who are on the younger side, and so that's my clinical practice. My background, neurology and actually math. But what I do now is a bit of everything. So I'm involved in a lot of just like Ron, a lot of clinical trials trying to figure out what are the best treatments or combinations of treatments for different stages of people with Alzheimer's disease related disorders. Taking some of those findings, and fortunately, I think we can talk about it a little bit more. We're at a very exciting era for us because we finally have biomarkers, so we can actually detect some of these diseases years before they show symptoms. And so we finally have a toehold with some biomarkers and a generation of drugs that are first generation drugs for Alzheimer's disease. So I've been involved in how you bring these drugs into clinical practice from clinical trials. Clinical trials are a very, very different structure. And so when you bring it to practice, you have to have the structure in place. You have to have proficiency, a lot more collaboration. So how do you do that safely? What are appropriate uses for these drugs? And then I'm also involved in practice guidelines. How do you incorporate the latest evidence into actually, being able to, in a timely way, detect and diagnose and disclose to somebody who may have symptoms, who may be worried. How do you incorporate the biomarkers? And then, evaluating these in practice. So involved in those. As far as the policy, just like you for the last, I just finally stepped down. I was the chair of the Medical Sciences Advisory Panel for Alzheimer's Disease International, which is also involved with the WHO and, trying to really promote advocacy and the understanding of what a big tsunami this is for all of us. We're all going to be impacted. So I've been involved with that. But I would say from a personal note, my lived experience is that I have a very strong family history on both sides. And usually when they're older. But on my mom's side, I was a teenager, and my aunt, who was like a mother to my mother and like a grandmother to us, who lived with us, started having issues and forgetfulness and other things. And I have to say, we didn't really have the language, the understanding of what was going on. And took care of her home. I used to, help her with her actively daily living, and she was a diabetic, giving her shots, and ultimately, she ended up after a major surgery having to go to a nursing home. I had to do that when I was young. My mom was away, and I had to do that, and it was very tough, I have to say. And then I remember growing up, and on my dad's side, my grandmother was older, didn't quite know us, kind of when we're familiar, but I didn't know what that was. And then I was already a specialist in Boston, and my dad was living with us, and he progressed. And so we took care of him at home for 10 years, and the last few years was very hard. And at the end, couldn't do that anymore. And so I think since then, I think probably, you know, half of my aunts and uncles have had this, and currently, you know, a couple of other ones right now. So, you know, this hits home. So you can see those things back here, right? I've been at this for a while. Cure AD. It's aspirational, but I think we can get there for our next generations. And those are, you know, licensed in Massachusetts and California. I have the one in Arizona now too. But I think it's a really hopeful stage, but it requires all of us to come together, think about brain health in early, even you know, early life, and certainly by midlife, and then recognize that, you know, people don't wake up one morning and have MCI. We'll talk about that. It's a process, and it doesn't tell you what disease you have. It's just this warning light just go on. It's like the, you know, orange light is going off, and you need to think about what to do about it. So anyhow, very, very excited to be here with you today and have a conversation with everybody.
Thank you, Ollie. And before we turn to Ron, I'll just say the point about warning lights really resonates with me. My family also affected many times in my grandparents' generation, but I was my dad's primary care partner. And when we saw the earliest warning signs, those lights going off, I wasn't sure what what I was seeing. And I've been doing this work as a non-scientist, non-clinician, but around these issues for decades. And I couldn't be sure, but we were fortunate that we had access to really high quality medical care, and docs and nurses and other professionals who listened to what we were seeing and gave a careful, thorough evaluation and got us on the right path. It didn't solve everything, but it sure gave us a lot more clarity than we would have had if
we'll talk about
left
that
on
right
our own.
today. I think we'll talk about why it's important, and also the stigma. We should get rid of that stigma. There's nothing wrong with it's important to recognize and talk about it and act on it.
Yeah. Well, thank you, Ollie. Let's go to Ron next, and then we'll ask Cynthia to bring us home.
Alrighty, thanks, Ian. I too appreciate the opportunity to share some thoughts with all of you today and join this group whom I know well, and I thinking that we've been at this for a long period of time, but I appreciate Ian, you and ABC bringing this topic to the forefront, because while we've been dealing with mild cognitive impairment for decades now, it's still a fuzzy term. And what are the boundaries around it? Where does normal aging end and MCI begin? Where does MCI end and dementia begin? These are all unclear, yet the construct seems to have gained some traction over the years. So again, I'm Ron Peterson. I'm a behavioral neurologist at the Mayo Clinic up in Minnesota. I had directed the Alzheimer's Disease Research Center here for about 33 years, just turned it over to one of my esteemed colleagues. I'm still directing the Mayo Clinic study of aging, which is relevant for this discussion, and then involved in a bunch of other NIH grants, the Alzheimer's Clinical Trials Consortium, ADNI, Alzheimer's Neuroimaging Initiative, and some vascular trials as well. So we started back with the forerunner of what was called the Mayo Clinic Study of Aging about 40 years ago, actually. And this study really involved our local community here around Rochester, Minnesota. That's where we live. And we started this study doing a random sample of people who live in the community. And we followed them clinically, longitudinally, with clinical evaluations, biomarker evaluations, et cetera, et cetera. And people ask me, how did you guys come up with the term mild cognitive impairment? How did you discover this? Well, we didn't. The bottom line is there were people in the field before us, Barry Reesberg, Steve Ferris at NYU, who came up with the label, but they used a particular staging scheme to define mild cognitive impairment. So what happened with our study of aging is we began to observe a group of people who really didn't seem to be quite normal, yet they were very functional, did not have dementia, so to speak. So there was this group in between, and we decided to put some loose criteria around them and see what happens. And then in 1999 published a paper in what was then the Archives of Neurology, now is JAMA Neurology, which sort of just described our experience. These are people we see, blah, blah, blah. Here are the criteria we put out for them. And all of a sudden, it sort of grabbed hold in the field, and people said, hey, I have these people in my practice as well, and I don't know what to do with them. They seem to be kind of in between. And I think that's what we'll be discussing today. And that led to our characterization of MCI criteria, imaging characteristics, biomarkers, et cetera, and has sort of become adopted clinically in clinical practice, inconsistently, but nevertheless. And now, fast forward, we have two disease modifying therapies out for Alzheimer's disease. And guess what? The clinical characterization, the most popular clinical characterization for these people is mild cognitive impairment. So I think it has sort of grabbed on and has gained some traction with regard to having some reality in clinical practice. So that's me. I'm a professor of neurology here, and I've been on several committees over time. Cynthia and I were together on a committee that dealt with terminology, believe it or not. And we'll get back to that. Ollie and I are on committees for appropriate use recommendations. Ian, as you know, I chaired the Napa Advisory Council for its first 6 years. For better or worse, I was on the DSM-5 criteria committee, the token neurologist on DSM-5 that came up with, again, some of these terminology issues. Then involved at NIA, was on NIA Council, the Board of Scientific Counselors there as well, the World Dementia Council and all. So I think hopefully I can shed some light on the longitudinal history of MCI, what it is, and hopefully a bit on where it's going. So let me stop there and turn over to Cynthia.
Thank you, Ron. And I'm now forever going to introduce you as our token neurologist, no matter
Token.
where
That's
we
right.
are and what we're doing. Cynthia, over to you.
Hi, everybody. I'm the Reverend Dr. Cynthia Hewling Hummel from Owego, New York. I'm a retired Presbyterian pastor, and I'm an author, I'm an artist, I'm an advocate, and I was started experiencing problems when I was 49 years old, kind of in my first parish, and I realized I was having some problems remembering the people in my parish, my ministry, and I was forgetting people's names and walking by them in the store. I was getting lost, and this was before we had GPS and ways to get around. One of the most problematic things I experienced is I was having trouble remembering what I read. I could read something and I'd put the book down and not remember it. I remember, forget, I should say, what I preached on Sunday for my sermon. And people used to joke, well, the rest of us have forgotten it too, but that wasn't terribly comforting. I went from doctor to doctor to doctor at age 49, and it took me 8 years to get a diagnosis. And my diagnosis at that time was amnestic, mild cognitive impairment due to Alzheimer's disease. The doctor had written that in. And I share this because I'm also, like some of you, I'm from a family that seems to have a history or predisposition to Alzheimer's disease. My mother died with Alzheimer's disease. Her only brother died with Alzheimer's disease. My maternal grandmother had some sort of dementia. So when I was going through all of these things with my doctor, his advice to me was, it's only going to get worse. And I left full-time ministry, and that broke my heart because I love being a pastor. But it pushed me into getting involved with the Alzheimer's Association, the local chapter, and led to my speaking and getting very involved on a national level, where I've met you and others who have been so influential in my journey. But I was thinking about my study. I've been in the ADNI study for 16 years. They've been watching my brain, studying my brain, as it were. And I'm now hoping to get into a pharmacological study because my Alzheimer's, moving from amnestic mild cognitive impairment, there's some increase in my symptoms and the things that I'm experiencing. But I really enjoy working with people in research. I serve on several committees, including the Alzheimer's Clinical Trials Consortium Research Participants Advisory Board. That's a mouthful. We meet with researchers as they design their studies to bring in the perspective of the lived experience, which is so important. I guess I'd just like to say that, it's been quite a journey for me. I think for me, one of the things that has been the hardest is how hard I am on myself. I used to be so smart. Now I have to, and I was the helper. Now I have to be the one asking for help in so many situations. But I'm still doing what I love to do, and that's helping other people and helping others who are going through this journey. So it's an honor to be with you, gentlemen. I was remembering, Ali, last summer we presented together, didn't we, in Toronto? I have to kind of remind myself of how I know people. I used to pretend that I remembered people and say, "Oh, how good it is to see you," and have no idea who I was speaking with. And now I've come clean, and I'll just ask people to remind me how we know each other. But it's wonderful to be at this table with you, my esteemed colleagues, and I thank you for all your work and your dedication to finding ways that we can diagnose it earlier and the treatments that we now have available. So I'm honored to be here at the table.
Thank you all. Those were wonderful introductions. And I hope our audience understands why I consider people, particularly Cynthia, but others who are living with and speaking out to really be our North Stars. And I will draw your attention, Cynthia, I don't know if you did this on purpose, but I'm very mindful that when you introduced yourself, you started by saying, "I am," and you described who you are, but you didn't define yourself by your disease. You said, "I am the Reverend Dr. Cynthia Hewling Hummel," and a couple of other things. Then you said, "and I have." So it's part of your lived experience, but I've never known you to define yourself wholly and exclusively by your health condition. And
that's true. But you wouldn't go around and say, "Hi, I'm a diabetic," or, "Oh, I've got breast cancer," or, "Oh, am I?" We define ourselves in my mind, by our experiences and then the things that are meaningful to us. Thank you.
Absolutely. Well, so thank you all for helping set the stage. And Ron, why don't we start with you? And if you could just walk our audience and maybe me too through what's a good, tight, precise definition, as best we have one, of mild cognitive impairment, and how do we separate that, both as clinicians and researchers, but also lay people like myself, from normal aging and dementia?
No, it's an important question, Ian, and I must say I don't have the precise answer there, but I think mild cognitive impairment constitutes that in-between category between cognitive changes of normal aging, whatever those are, and we can talk about those, and dementia, where dementia is defined by I'm no longer thinking as well as I did, remembering as well as I did, and it's affecting my daily function. So I now need help with doing my daily activities, whatever they were. Back a little bit then to the MCI stage, and now usually memory, but not always, but my memory is not what it used to be and maybe not what it ought to be. I know I'm having trouble remembering. I need some help. Those around me know I'm not remembering quite as well. But to the casual observer, I look okay. I'm still driving, paying the bills, doing the taxes, all that kind of stuff. But I do need some help with the memory issue. So that's kind of the in between. And it's important, as Cynthia knows very well, that in our group that met for years, it seemed like, we came up with the notion that there are syndromes, which are clinical pictures, and then there's the underlying disease process that causes the syndrome. So MCI is on the syndrome continuum: normal aging, MCI, dementia. So clinically, we'll characterize people as to their clinical syndrome or their clinical picture. Then we ask the question, what's causing it? And here's where Alzheimer's disease comes in. May or may not come in, but it can come in as a cause of that syndrome, either at the mild cognitive impairment stage or the dementia stage. But MCI could be due to a bunch of other things that are not Alzheimer's disease related. It could be medications I'm taking for my hypertension or my diabetes or my COPD that are having side effects affecting my memory. It could be psychiatric issues, anxiety, depression, etc., affecting my memory issues. Sleep is a big factor, that sometimes sleep disorders can impair memory during the day, such that you diagnose sleep apnea, you treat sleep apnea, and the MCI goes away. It goes back to normal. So that can happen. So MCI need not be the early stages of Alzheimer's disease, but it often is. So I'll finish in just a second and say the toughest question, Ian, is the one you initiated, is what's the difference between normal aging and MCI? And it's hard. It's not hard and fast there. But usually what I look for is there a change in this person's memory pattern? Is this person now having trouble forgetting information that he or she formerly would have remembered? Important stuff. If you're a golfer, I got a tee time on Tuesday with my buddies and I don't show up. Again, things happen, that can happen. But that happened 2 weeks ago, and it's going to happen a week from now. So when these forgetfulness events of things you formerly would have remembered well are starting to become forgotten, and that's a pattern that's increasing in frequency. It doesn't mean you got MCI, but it does merit a further look.
Great, really helpful. And Ollie, to follow up with you on a couple of elements. Not everything is Alzheimer's, and not everything, as Ron listed, are these reversible other conditions like a sleep apnea, hormone imbalance, other things that maybe can be just totally corrected. So you've also got the so-called related forms of dementia, related disorders like frontotemporal degeneration, Lewy body, et cetera. Would we say that someone can have MCI due to FTD or LBD or something like that, or would we use different nomenclature for a pre-dementia stage there?
It's a good question, and sometimes we get caught up in our own terminology.
Yeah.
But if you look at the continuum of unimpaired, mild cognitive impairment, dementia, that can happen with any kind of underlying disorder. So there is an MCI stage of dementia with Lewy bodies. That is the prodromal stage for that. FTD FTD can present with behavior, it can present with language, and a variety of other. But there could be the earlier stages of those disorders where you're not functionally impaired, but you're starting to become somewhat symptomatic. So theoretically, yes, MCI can precede dementia in any of those disorders.
Right, but it just, to your point, Ron, it might look different either to the individual, right, those that are in their ecosystem as family and friends, and or their clinicians.
Right. And often the cognitive profile is different. So in dementia with Lewy bodies, on that spectrum, people may have difficulty with speed of processing, visual spatial skills, and not so much memory. So other cognitive domains become involved. You put that together with perhaps REM behavior disorder or other clinical features, and you become suspicious that this person is on the continuum, but maybe now just at the MCI stage.
So, may I add something to that?
Yes, please.
That's really, really important because, we have general trends for populations that we're pretty good at, saying, well, for a population, as you age, your motor speed goes down, your ability to learn and remember information will go down for a population compared to at age 60 compared to, 20-year-olds. The individual trajectories of aging and even disease manifestation and the symptoms are so variable. And then ultimately, when somebody's in their 70s and 80s, once you start having problem with one of these proteins for a while, 10 years, 15 years, like in Alzheimer's, we have the amyloid protein causing the plaques, and you have the tau protein phosphorylated causing the tangles. It starts to affect many different things. It starts to affect blood vessels. It starts to affect the energy producing organs, the power cells of the neurons. It starts to affect the garbage collection system of our brain. So then you're more likely to actually have other sticky proteins. So you end up having a soup. And, by the time, we have these studies here in Arizona, the brain and body donation program, we follow people for 20 years, 30 years, and then they donate their brain and body. And we know that Alzheimer's disease is probably the most common driver of somebody who has a dementia syndrome when they're older. But it's so uncommon to find Alzheimer's changes in the brain by itself. So you end up getting a little bit of the other stuff. And so the question is, what's driving the cause? And when you say, MCI due to MCI, Ron and colleagues have done such an amazing job. It is a bona fide medical condition. There is an ICD-9 code for it. So MCI doesn't mean normal aging, but MCI doesn't mean Alzheimer's either. Right? So you could actually have MCI, and you take care of certain things because they're drinking too much, they haven't been able to sleep, so they're taking diphenhydramine, which is Benadryl, all the PM drugs, and then so between their sleep apnea, the drinking, and the Tylenol, guess what? You do that for a few months, we're all going to have MCI, right? And so that's a very different, that's very different than if the driver is Alzheimer's changes. And what's most common is you have a combination of things. So it is important when these changes are noticed, they're not stereotypes. So someone with Alzheimer's disease can start with having executive problems, having less mental efficiency, difficulty multitasking. They may seem more withdrawn, sleep issues. It doesn't have to be memory first. But the important part is to recognize there's a change, not attribute it to normal aging, even though these symptoms can be common as people get older, and get it and look into it. That's the most important thing, because it's a high risk condition. And the risk really depends on what are the drivers. And even if you have Alzheimer's changes in the brain and other things, it doesn't mean that we can't actually slow things down and make your life better. And that's the important part to know. And you want to do that and give people that power at the earliest stages when they get to choose, as opposed to later on when a lot of damage has occurred.
Thank you for that. And Cynthia, before I go to you, I just want to let our audience know we've got about a half an hour left. In about 12 or 13 minutes, we're going to turn to audience questions and do the best we can to work through responding to as many of those as possible. Please use the Q&A function in Zoom. For me, that's down toward the bottom of my screen. I have to hover with my mouse toward the bottom of the screen to get a pop-up of a menu. And one of the choices is going to be for Q&A. Feel free to put in questions. If there's anything we don't get to today, if you have identified yourself as anything other than anonymous, we can always follow up with you after this session to give you an answer for anything we didn't answer live. So we'll get to that in, again, about 11 or 12 minutes. Cynthia,
can I ask something from Cynthia? Cynthia,
sure.
You went 8 years, right? This is not for young people, this is not a typical situation, unfortunately. Years and years where people go. So what were the different things that you were told?
Well, when I went from doctor to doctor, the first thing was menopause. The second thing was stress. I went to a sleep clinic. I went from doctor to doctor to doctor, looking for answers. And because I couldn't get a PET scan at that time, and the reason was the insurance wouldn't pay for it, because if it were Alzheimer's, there was no cure, there was nothing they could do. So I put the money into the PET scan. So fortunately now we have new ways of diagnosing, with the blood, and the p-tau and the other ways that we can now test at an earlier time for people. So that's so hopeful. It's such a hopeful time. But I asked my doctor, how long did I have? And he said, 6 years, maybe more, because I also learned that I was homozygous ApoE4. So again, that was an increase in risk. And with my family history, it wasn't a surprise, but it was a sadness.
Cynthia, thank you for defying the experts. So I want to pick up on that question that Ollie asked, and when you did get a diagnosis, uh, were you asked to consider going on any medications for any of the symptoms when the disease modifying therapies began to get approved a couple of years ago? Were you offered, and if you're open to sharing, did you make any
Yeah.
decisions about potentially using any of those medications?
I never took any of those medications. I'm not sure that I was offered them, so, when doctors would ask me at my visits, what am I on? My thyroid medicine, but I was thinking about all the changes that I knew something was wrong, but because of my age and they were just having trouble kind of trying to zero in on what it could be. And for me, it was a sense of shame. That I couldn't do what I used to be able to do, that I had to ask for help for so many things if I was, and now I'm really upfront. This is what I need to succeed. But back then it was much harder. And I was just processing things so much more slowly. One of the other things that I was experiencing, Ian, was I always carry earplugs now because when I'm in a sensory overload situation, I can't focus and I start to feel a panic. So going to the movies or trying to follow a TV show or people who tell jokes that I'm trying to figure out, well, how is that funny? I just don't process. I miss reading, but now I discovered podcasts. Do I remember them? No, I do not. People will say to me, surely you remember this. And that's not a helpful thing to say to somebody who's got a memory disorder. Instead to say, well, I remember a time when we did this, just a different way. But living alone, I think in many ways has helped me because I have to do things on my own. There's nobody to help me. Yes, I can ask a neighbor if I need something, right, a ride to the hospital or whatever, but on a day-to-day basis, I've got to kind of lay out my day, lay out my week. I write everything down. I check it off. I take pictures all the time, so I can remember who I was with. And as I said, my hardest thing is that short-term memory. I can meet somebody and turn around and introduce myself to them again. Hi, I'm Cynthia. Yes, we just met. Because I don't know. But it's challenging. But I'm grateful to be able to continue to participate as an advocate. And I really think of it as my ministry. So that's a long-winded answer, but
Oh, perfect. So Cynthia, just to follow up a little bit, none of us on this call, none of the people that we work with and try to serve would ever trivialize or minimize the losses that are associated with mild cognitive impairment, or if that should progress to dementia with any of those losses. They're incredibly serious and can be heartbreaking. That said, I know you and I have talked a lot over the years about what some maybe in a little more academic circles than mine would call a strengths-based approach. And I've just thought of it as, and I did this in supporting my dad, trying to focus more when I could, more on what my dad could do and what was meaningful to him, what he retained, rather than dwelling constantly and obsessively on the losses. And so bringing this back to your experience, I know one of the things you've shared with me and with many others is that music has been a very important part of both your ministry and just your personal pleasure in life. Can you share with us how that's going? Are you still able, is that one of your strengths that you're able to maintain, and how has it been affected, and what does it mean to you living a whole rich life?
Oh gosh, that's a great question. Well, my band has a gig tonight. We're opening up Summer of Roses concert series tonight in Rose, New York. I love to sing, and I sing a little bit of everything from rock and roll to country to sing-alongs. And I tell you what, I remember the words. My band, we sing in a nursing home. We've done this for how many years? More than 10 years, I think 13 years. At a nursing home, we sing there once a month, and we get the residents singing with us. And so many people who maybe don't do a lot of conversation in the normal course of the day are singing along with us and clapping to the music. Music awakens people. Doing art is another thing that I've been very active in. I teach art classes usually once a semester at different universities on how art can help us process what we're feeling. I try to focus on the positive, the things that I can do. I love to go swimming. This morning I got up and drove to the YMCA and I did my laps. Staying physically active helps me just feel energized. I mean, I don't watch a lot of TV. I think getting out and exploring, the world is uh, me a better choice. I was thinking about how much I enjoy just being with other people and chatting. But again, it can't be in a very loud environment. Um, I don't know if I answered your question, but
You
those are
did.
some of the things that help me. Volunteering is the last thing I always like. When you help others, you help yourselves. And so I tell my friends and people who've been newly diagnosed, find something that you can do to help somebody. Help in the library, help in the senior citizen center, go to the dog pound. Do something, because when we help others, we just elevate ourselves and how we're feeling about ourselves.
Purpose-driven life, my friend.
Yeah,
Yeah.
yeah.
I could, I'm going to throw a couple of combined questions at you and Ron, but if Ali, if you could start. When clinicians are thinking that maybe they're seeing something that isn't quite right, or they're hearing from a patient or a patient's family member or friend that something maybe isn't quite right, how can a clinician responsibly initiate that conversation, taking into account the possibility of mild cognitive impairment due to one of these underlying neurocognitive disorders? Do it in a way that is empathetic and empowering, not stigmatizing, not terrifying. And the second part of this is what tools, either long-standing available tools that still are good and functional for clinicians, or new and emerging tools are there for clinicians, maybe at a primary care level, to get that conversation started and detect started, or at a specialist level for formal diagnosis? Can you kind of walk us through how do you have those clinical conversations, and then what tools are at your disposal?
Sure. Thank you for that. Ultimately, it has to be personalized, and you have to align with the patient and a care partner, and maybe bring someone else into the conversation. So, for folks who want to go dig this up, or for clinicians, I was part of a group. 7 years it took us. It was an Institute of Medicine aligned process, but we actually came up with clinical practice guidance and guidelines that it was published a year ago. So if you put Alzheimer's and Dementia Journal, you go in there and you'll see the special collections, and there's a whole issue of it that has the executive summaries that actually the process of how you should go about having the conversations, practical tips, what things you should in a structured way go through, and what tools to use. One of the executive summaries, for example, is all about validated instruments. And it's agnostic, but it actually gives you tables and tables of, well, this is the MoCA, the Montreal Cognitive Assessment. This is the MMSE. This is the Blessed. Where can you find it? Here's the PDF, link to it. What are the strengths? What are the limitations? And you do it. We have those for every for activity of daily living, to look at depression, mood symptoms, et cetera, et cetera. So that and putting it in a flow so the clinicians know when to when to refer. But ultimately, that conversation, the clinician must be comfortable themselves about that, not have stigma, and really believe that this is something very, very important. And ultimately, what we know is that, regrettably, maybe, and Ron probably knows this, absolutely knows this better than I do, but the numbers that I've seen are somewhere between maybe 8 to 15% of persons and get diagnosed with MCI who are in those stages. So we're losing this opportunity to talk to people about these things. So there's ultimately, if you know the person and there are symptoms of concern, I think you want to be able to be very, very open about discussing how important it is to do an evaluation, to get a baseline. and come from the focus of
Hmm.
what is your goal? What are your goals for the next 5 years, for 10 years, for functioning, for brain health? And coming from that context also. Because we've become so good at, taking the medicine for the blood pressure or the medicine for the cholesterol, right? Well, this is no different. We want to know if you have a high risk state and what we can do about it. And putting it in a very
Hmm.
positive light, because it should be positive. It's knowledge that's going to empower a person to make their own choices.
Great, really helpful. And
Hmm.
Ron, before I go to you, and I'm going to ask Ron, if you don't mind, kind of drill down on these tools, particularly the new and more innovative tools. I'll just set a bit of landscape. So Cynthia mentioned having to pay out of pocket for a PET scan back in the day. The good news is, starting, I think, about 3 years ago, I may be a little off on my timing, Medicare now pays for a PET scan when ordered by an appropriate clinician to try to evaluate for the potential of Alzheimer's disease. But could you talk about some of
Hmm.
the new innovations, biomarkers, where we are today,
Sure.
and where we might be headed? And then we'll go to audience questions.
Sure, happy to, Ian. So again, keeping in mind that we're trying to drill down on what is the cause of the syndrome, the clinical picture, MCI being one of those. Of course, we look for any kind of treatable, reversible elements that we talked about. So we may check some blood studies and make sure there's sleep habits, et cetera, et cetera. But if those are all in line, then we think about, gee, could there be a new neurodegenerative disease contributing to this picture? And now we can start looking for biomarkers that are specific for the underlying neurodegenerative diseases. And in the Alzheimer's disease arena, now we have been fairly fortunate recently that we can find some fairly specific measures that could be contributing to the picture. So, how do we, if, as Ali was saying, we define Alzheimer's disease biologically by the presence of plaques and tangles. Plaques are made of the protein called amyloid. Tangles are made of the protein called tau. Well, now with imaging devices, we can do a PET scan specifically for amyloid, a PET scan specifically for tau, and determine if those two proteins are present in the brain. We can also do it with a lumbar puncture or a spinal tap, because we can measure the proteins in the spinal fluid. That's been around for decades. But the new kid on the block are blood tests, and Cynthia alluded to those earlier. So now there are blood tests that will give us an idea, particularly if there's the amyloid protein in the brain, maybe a little index of the tau protein as well. And of course, these are readily available. But be careful, they're not the end all be all yet. And many of us are stopping short of saying, you got a memory problem, get that blood test to see if you got Alzheimer's disease, because it's a much more complicated picture than that. So I think blood tests have a great deal of potential. I usually think about them in three areas. One is prediction. Will a blood test predict whether or not I'm likely to have amyloid in my brain? The answer is pretty good there. The second is make the biologic diagnosis of Alzheimer's disease. Probably, maybe not quite yet, but can give some important information. And the third one is following therapies. So if somebody goes on a disease modifying therapy for Alzheimer's disease, can we get a blood test to follow it? I sometimes use the cholesterol analogy that
Yes.
sometimes if we treat cholesterol hyperlipidemia, we give them a statin and then we follow their blood tests down the road to see if in fact they're working. They're not there yet for the Alzheimer's proteins, but they're pretty good. So I think there are the biomarkers out there now that are helping us a lot. But I made one caveat with that. What they will tell you is whether there's an Alzheimer's disease component to your picture.
Yes.
Doesn't mean that, gee, all my cognitive problems are due to Alzheimer's disease. As Ali was saying, most people have a variety of things that contribute to cognitive impairment. So keep in mind that Alzheimer's disease is not all or none. It may be just part of the picture for anybody's given clinical symptoms.
Great, really helpful. And Cynthia, I want to direct the first audience question to you. From your perspective, what are the emotional, social, practical realities of living with I should say, early cognitive changes, whether it's Alzheimer's or something else? what are the practical implications of that for your daily life that you think are often overlooked, either by clinicians, family members, or other people that are facing their own cognitive impairment symptoms?
That's a great question. I'll start with a clinician. I spoke with somebody yesterday on the phone who wanted to give me the information I needed for an upcoming appointment. And that person rattled off so much information at that time. I said, whoa, slow down. I've learned to advocate for myself. I need this in writing. I can't just have you tell me this. There's no way I'll remember it. Can you email me this? Can you text me this? I need to see it, or I won't be able to follow through. So I think it's for me becoming an advocate for myself, speaking up when I'm in a doctor's office, making sure that I get a printed report that they go over with me, that it's not just something that is put in my chart. I want to understand, what are the next steps, what was discovered. So I think for me, also people making assumptions when I share my diagnosis. There's people who say, "Oh, you look fine to me." Golly gee, she's just looking for attention, that kind of thing. Well, they have no idea, that I'm spending half my day looking for my purse or my phone, or it's very frustrating when then other people see me make an error like that, it's one thing that I can forget something and then find it later myself, but when other people are aware of my problems, I think too, when I have to ask for help, or the other thing I remember from one of my earlier visits is, don't you have anybody to come with you? Some of us live alone. Some of us who have a diagnosis of MCI or Alzheimer's live alone. And I think it's challenging, and but that sense of, isn't there somebody that would care for you enough to come to this with you? And that leads me to research. So often people who want to participate in research, but maybe don't have somebody living with them, have to really scramble to find somebody. And this really isn't part of our conversation, but thinking ahead of as we have research and you're looking for people to participate, are there other ways to work with people who want to be involved? Which is kind of a different topic, but something that I'm always thinking about. Did I answer your question, Ian? I've forgotten what it is.
You did. That was great. And I won't go into this in the interest of time. It made me think a lot about my relationship with my dad as he went through some of these things, but also folks that weren't part of our family, but were trying to be supportive. Didn't always know the right thing to do, but I think in time, most of the people who really cared about my dad learned to ask and offer rather than just impose themselves into his life and try to do things for him without finding out first whether he wanted those things done for him or whether he wanted to give it a shot. And more often than not, he did fine until the Parkinsonian symptoms made some of the physical activities impossible for him. He wanted to and could do a lot for himself. And I think that was empowering for my dad. And to your point about how you have lived alone all these years, and that's been good for you because it's been a challenge that's made you rise to the occasion. Super important, and something that I hope clinicians, to the best of their ability, and family members will reinforce and support. I want to go to the next audience question. What are we training primary care practitioners to do with and for patients and care partners once MCI has been established? And maybe, Ron, if you could lead this one off, and Allie, if you'd like to add anything.
Yeah, clearly, as we move earlier and earlier in the clinical spectrum, the role of the primary care physician becomes increasingly important because most people will go to their primary care person with, gee, I'm not remembering as well as I used to. Is this Alzheimer's disease? And I think primary care people are really paying attention to this. Very busy schedules, right? They get 10, 15 minutes with a patient who has diabetes, hypertension, COPD, etc. Where does memory come into play? But I think paying attention to it and pursuing it a bit further now, and maybe not at this visit, but say, let's get another visit now where we can really drill down on your memory issues and try to get a more insightful diagnosis, because mild cognitive impairment, as we discussed, can be a difficult and subtle diagnostic entity. One thing I can say about what we were discussing earlier is the screening instruments that are out there. There's some very good ones. Ali mentioned the MoCA. There's, of course, the Mini Mental's been around for decades, the slums, a whole variety of these tools. I think they're very important to get a rough assessment of how a person is doing, but I stop short of making the diagnosis of MCI based on just one of those instruments. I think these instruments can give us an index. We need to go a little bit further, drill down on the individual patient, somebody who knows the patient well, maybe get additional cognitive assessments and all. But these tools are very important, but often not sufficiently sensitive or specific to really nail down the diagnosis.
Great, really helpful.
If I may, there was I think Joe Costello, I think was asked I think a very similar question. So I tried to answer it in a Q&A. So that's available to others also, and also put in links for that clinical practice guidelines so people can go there. I also put in links to the appropriate use recommendations and for the who, what, when, how, if you as a clinician is considering using the plaque lowering drug. So I put those in there so people can have those links. But I think what Ron was saying is very, very important. There is oftentimes this cannot be done in primary care in one visit. It requires multiple conversations. But one thing that was a very, very I think a recommendation that all of us in the work group for this had, nurse practitioners, primary care geriatricians, in addition to geriatric psychiatrists and neurologists like myself, is that it's really important to use a validated instrument. You can tailor the questions to the person, but ultimately, you use a validated instrument like, SLOMS or MoCA, et cetera. But that number doesn't define a person ever. Right? It always has to be integrated with all the context and the history of what's changed. So is this person somebody with, a PhD degree, or is this somebody with, eight grades of education with English not being the primary language? That interpretation of those test scores are very, very different. And so one of the things that the CPG, the clinical practice guidelines, does is it says, if you're not confident, here are the things you can do. So refer for neuropsychological evaluation. Why? What is the question to ask? What are the tests at that stage to do? Because ultimately, if you've decided somebody has that MCI, let's say that it's correct that they actually have the MCI stage. Now you got to get to the root. So what other things would you do for everybody? So here's the blood panel. We call it a cognitive blood panel that should be done in primary care on everybody. And we give the rationale about why. This is the brain study, which is a structural study. It's an MRI of the brain that should be done. Why do we do that? And then down the line, there's recommendations about how to use these other biomarkers, like Cynthia mentioned, and in what setting, whether it's the amyloid PET scan or spinal fluid or a glucose PET scan or other tests that you would bring in. But all those have different indications, and you have to focus on the person. So not a shotgun approach.
Great.
Ian,
So, yes,
can I just add, I think the worst part of going for my yearly visits or however often I go is the memory testing, because I'm very aware of how poorly I'm doing compared to my old self. And I often just need a box of Kleenex right there. It's very hard for people sometimes to think about what they've lost. And I think it really is helpful that the staff be aware of those feelings and make time to talk about them or to help people to process it. Just my experience.
Yeah. A beautiful and important point that we need to think about the whole person and what they're experiencing, not just about the technical side of this. So I apologize because I'm gonna put Ron on the spot here for a very pithy answer for a much more complicated set of issues. But we've got less than a minute left, and I have to wrap this up. We know there are huge disparities in the numbers of people that get MCI and some of the underlying diseases Women are at much higher risk, people of color, people who have less healthcare access or live in areas of the country where it's harder to get access. How can we address misdiagnosis and missed opportunity for diagnosis, particularly for people that are at greater risk for these diseases or are at greater risk for missed opportunities in the healthcare system?
And sometimes I can add to that individuals who are less likely to relay these information from various communities may not be willing. So I think here's where it takes a sensitive clinician to know his or her patient population. What are the issues out there? And to focus on that if we find something, it doesn't mean the end of the world. It doesn't mean Alzheimer's disease. And sometimes, as Cynthia was saying, I try to focus on, is the glass half full or is the glass half empty? And the glass half full is often in the MCI world. There's still a lot of things people can do. So I think trying to bring those communities in to share these thoughts with the clinicians as to whether something's significant, meaningful, or not.
Great, thank you. And remarkably pithy, given the breadth of that question. I promise our audience, if you're able to join us for sessions 2 and 3, we will try to have more time for some of the questions we didn't get to today, including digging more into the health equity issues and the disparities. But I want to thank you all for joining us today, and I particularly want to thank our esteemed panel of speakers, Drs. Autry and Peterson and Reverend Hewling-Hummel. Please join us the next 2 Thursdays if you're able, June 11 and June 18. We'll be continuing this conversation with some new panelists to focus on managing MCI in a clinical sense, and including both the clinical care and the community supports that are available. And then in our last session, promoting brain health and scientific innovation. So we could do this as an 18-hour series, but we're going to get it done in 3 hours. Thank you for joining us today, and I hope we'll have you back with us on June 11 and then June 18. Be well, everyone. Thank you.
Thank you. Bye-bye. Thank you.